I'm Kathleen Carter. I'm from Virginia Beach, Virginia, and I'm going to speak to you today about aortoiliac ultrasound, including following placement of aortic endografts and how to assess those. The reason that we perform aortoiliac ultrasounds is usually to follow up aneurysmal disease or to identify it. We're looking for atherosclerotic disease and stenoses. Sometimes physiologic testing will indicate that there's inflow aortoiliac disease and we want to define that more precisely, or to follow up after open or endovascular repair. Other indications would be claudication that interferes with the patient's occupation or lifestyle, usually one that would indicate that there's inflow disease such as the hip or the buttock area. Abdominal bruit or decreased femoral pulses may prompt an exam of this sort, or postoperative findings after angioplasty or stent to look at that and how that is faring. It may be emboli in the ischemic digits that prompt the exam, or again follow up to any kind of revascularization. So let's begin with aortic aneurysm and just quickly talk about that. The incidence of aortic aneurysm in the general adult population is about 60 per 1,000, and it is the 13th leading cause of death in the United States. 15,000 patients die annually from ruptured aneurysms, and there are more than 50,000 aneurysm repairs, both surgical and endovascular, annually. This occurs more often in men than women. It is mostly infrarenal, but can be suprarenal or, of course, thoracic. It is usually defined as a focal dilatation of greater than or equal to 3 centimeters. Some literature says 3.5 in AP diameter. In general, if they are under 4 centimeters, most centers will observe those. Once they reach about 5 centimeters, they are a candidate for elective repair, and once they get larger than 5 centimeters, usually patients that are candidates are offered surgical or endovascular repair. Of course, if there's rupture, then they would require immediate attention and repair. Aneurysms are usually in 2 forms, either fusiform or saccular. Fusiform aneurysms are fairly easy to turn and get into an orthogonal or perpendicular plane and measure. Saccular are a little more difficult, and sometimes it requires the plane of either the sagittal or the transverse to accurately measure those. Here's normal aorta. You can see the walls are nice. There's no ectasia associated with this, as opposed to this image in which there's aortic ectasia as well as the dilation in the distal aorta. The most common sites for aneurysms are aortofemoral, popliteal, and those are bilateral about 50% of the time, and iliacs. And the most common complication associated with the aneurysm is distal embolization and thrombus. And again, these can be fusiform or saccular, but most of them are fusiform. Let's look at an iliac aneurysm case. We often see iliac aneurysms associated with aortic aneurysms. This is a patient who had an infrarenal abdominal aortic aneurysm on CT scan with left common iliac artery involvement, and had an ultrasound to confirm the hypogastric artery prior to embolization, and this was to be done prior to an intervention. So here's the iliac aneurysm. You can see that a large portion of it is thrombosed, and you can see the thrombus in it. It's a very large aneurysm, over 3.5 centimeters, and in the sagittal view you can see it extends all the way to the level of the bifurcation, so that is why they want to address this patent hypogastric artery. And we need to define the size, document the flow through that, so that we know post-hypogastric coiling what will be going on with that. So here's the documentation of the spectral waveform of the hypogastric in preparation for that coiling. In addition to aneurysms, we're looking for dissection disease. Here you can see the intimal wall of this aortic dissection. Here's another example in transverse, and then that same artery in the longitudinal view. Here's an interesting aortic dissection. You can see that this is curved up in this direction. This patient had recently undergone a renal intervention in which a catheter was approached in this direction. There's a large mound of plaque here, and when the catheter hit that plaque, it was forced downward and lifted the intima. And this was during certain portions of the cardiac cycle, waving and opening and closing. It was not causing enough of a hemodynamic impact to address it at that time. We're going to also look for aortic stenosis. We're going to look for iliac stenosis. Aortic occlusion or iliac occlusions. Here you can see an occlusion at the level of the terminal aorta with collaterals coming off. We are confirming with spectral Doppler that that was actually occluded, and as well as with color and B mode. Now, iliacs, once they've been chronically occluded, are very difficult to see. They begin to blend in with the surrounding tissue, and so you really need to use your vein as your landmark to help you see it and find it, and then you can put your spectral Doppler in where you see the sort of atretic artery and confirm that there's no flow when you suspect occlusion. So now that we've talked about the types of disease that we're going to be looking for, let's talk about how we do that and what the role of the vascular laboratory would be. Well, we're going to determine whether or not there's disease present, how severe is it, precisely where is it located, and we may be able to assist in determining therapeutic options for those patients with stenoses or disease. The pre-intervention, we're going to talk pre-intervention, post-intervention, and then we're going to talk about aortic endografts. The pre-intervention duplex complements the physical assessment done by the physician on the patient, as well as any physiologic testing or angiograms done prior to the duplex ultrasound. This is more specific localization of the disease than the physiologic test, and we can determine primarily, is that disease focal or diffuse? Where is the exact location of disease? How severe is it in terms of percent stenosis? What's the length of the stenosis? If there's going to be an endovascular intervention to this, that might help them determine the size of the balloon or the catheters that they're going to use. And if there's adequate visualization, you can measure the external diameter and residual lumen, and that may assist in determining what appropriate endovascular device to be used to address this problem. What do you need? You need high-resolution duplex ultrasound. This is not a study that's probably best done with one of the smaller laptop-type systems because you need really strong, good, robust color and spectral Doppler deep in the abdomen. You're going to use lower frequency transducers and perhaps use several of the transducers, maybe a curved and a linear, and you may have to go to a phased array or an annular array based on the patient's body habitus. We usually keep these patients NPO, don't normally do a bowel prep for them. So the technique would involve a thorough examination of the entire aorta and iliac segments in both transverse and sagittal planes. However, the abdominal aorta and the iliacs are usually best imaged in their long axis, but transverse will help you identify the course of those vessels. Lower frequency pulse Doppler transducers, high resolution, always less than 60 degrees in the center stream of the vessel to document the velocities. Color flow is very helpful. Iliacs are often very tortuous and deep, and of course we always have to deal with overlying bowel and gas. You may need to turn the patient, you may need to use differing approaches to be able to access each segment of the iliac arteries, and we found that the lateral decubitus position is really a helpful approach. This picture is a 3D reconstruction of a 1 millimeter CT, and you can see here that this is quite an angulated aorta, and you can also see how tortuous these iliac arteries are. And even though a standard axial CT would drop the plane this direction, we're able to put a plane in these CT scans in a orthogonal or perpendicular approach, and that's what we do with ultrasound to be able to accurately measure the residual diameter here. You need to recognize that there are some limitations and challenges to this examination, obviously obesity, poor cooperation, and it is sometimes very difficult due to this tortuosity to obtain adequate angles under 60 degrees. So it requires some due diligence to do that. We're going to use imaging color flow and Doppler and sample a spectral Doppler throughout, usually proximal, mid, and distal in the common iliac, proximal, mid, and distal in the external iliac, the origin of the internal, and then the femoral bifurcation. You want to be parallel to the wall, and you want to make sure that the Doppler cursor is parallel to the wall and as you go through each segment. And as I said, that is going to take some manipulation to be able to do that adequately at under 60 degrees in tortuous vessels. So we'll look at the aorta, proximal, mid, and distal, and then the iliacs, including the hypogastric or internal iliacs, and using the image, B-mode image color flow and Doppler, we're going to assess this thoroughly. Spectral waveforms are collected throughout the aorta and iliac segments, and then I normally would collect the runoff vessels of common femoral SFA and PFA origins as well. Special attention is then paid to color flow patterns where you can see if there's elevated velocities that suggest a stenosis. This is what we want to see. This is a nice, normal, triphasic, high-resistant iliac waveform with a nice spectral window and return to forward flow after the reverse flow component. You can see that this is parallel to flow, nicely parallel and an appropriate angle. This is the kind of disease we want to document. You can see there's a huge aortic, common iliac bruit here that is causing all of that color speckle within the area, but this is from a severe common iliac stenosis. We can see here that this is over 500 centimeters per second, certainly a hemodynamically significant stenosis by anyone's criteria. In order to determine that there's at least a 50% stenosis, we have to have a doubling of velocity plus post-stenotic turbulence documented from, so we would have a doubling of velocity from the segment of the artery prior to the stenosis as compared to the highest velocity within the stenosis, and then we'd want to document that post-stenotic turbulence. Here's another example of a severe common iliac artery stenosis over 600 centimeters per second. It's aliasing, and the loss of the reverse flow component, certainly a very stenotic. Here's an example of an external iliac stenosis. So here's what I was talking about. Here's the pre-stenosis waveform. It is monophasic. It doesn't have a diastolic component. Then we get into the highest velocity and then document the post-stenotic turbulence distal to the stenosis. And you can see here how color will help you place the Doppler in the highest velocity segment where that's aliasing. Don't forget about B mode. B mode can show you also where the plaque is, and you can sort of get an idea of where you're going to be putting your spectral Doppler to confirm whether or not this is a hemodynamically significant lesion. This is an example of diagnostic criteria. Some centers will use greater than or less than 50% stenoses. Others will break that down further into 50 to 75 and 75 to 99 based on these criteria. Occlusions, of course, you have to confirm the absence of flow, and normally we'll hear a pre-occlusive thump just proximal to the site of that occlusion, and then confirm that it's occluded within the vessel segment that is occluded. So let's look at a case. This is an aortoiliac case of a 75-year-old male with bilateral lower extremity claudication. He had calf pain at 2 to 3 blocks. He had the other usual comorbids and was a prior smoker. The study was prompted by decreased femoral pulses with absent distal pulses, although he had patent Doppler signals at both the DP and PT. He did undergo a physiologic study that showed likely aortoiliac disease, and an aortoiliac duplex was ordered to define the extent of this disease. So let's just walk through what we would normally collect in a complete exam of this type. We would look at the proximal aorta, the mid-aorta, and the distal aorta. We would be looking for any aneurysmal dilatation as well as any stenoses while we are assessing this in both transverse and longitudinally. Then we look at the origins of both common iliac arteries, and you can see that there's quite a bit of difference in the waveform here. This is a much more normal waveform on the left, where there is some reverse flow component, as opposed to this on the right, where it is a monophasic waveform and there's no reverse flow component. So we're going to be keeping an eye out on that. The right common iliac was patent throughout, with about 100 to 125 centimeters per second. As we come down into the right common, we see the bifurcation of the hypogastric or internal iliac, and then the proximal or proximal to mid external. As we get just a little further out in the external iliac artery, we see a step up in velocity of almost 500 centimeters per second, with additional increase in velocity at the origin of the internal iliac artery. Again, over 400 centimeters per second. Here's a depiction of where that is by color flow. You can see in the external iliac right where that lesion is occurring. And then distal to that we have the post-stenotic turbulence and decrease in amplitude and velocity, and the waveform is quite disturbed, which confirms that that's a hemodynamically significant stenosis. Finishing out that side of the exam is documentation of the right common femoral artery and the runoff vessels PFA and SFA. All of these vessels then are monophasic. We then go to the left, and we again see the left common iliac artery origin, and there is some step up in velocity there, but it doesn't double from the previous segment, and there's no real poststenotic turbulence associated with that. We continue on down the rest of the common iliac and then get into the left internal iliac artery, which, similar to the right, also has an elevated velocity, and continue down the rest of that segment as well. When we got down to the level of the femoral, we noticed that the left SFA is occluded and confirmed that with spectral Doppler. And here is a left profunda adjacent to that that's 251 centimeters per second. Here's the PFA distal to the origin. And so the question is this PFA stenotic with this step up in velocity? Well, the answer to that question is there's no poststenotic turbulence here. And this PFA is simply compensatory for the occluded SFA, so it's not really stenotic. The impression on a case like this would be hemodynamically significant stenoses of the right proximal to mid external. Remember, we had that very high velocity with poststenotic turbulence. Bilateral internal iliac or hypogastric stenosis. Bilateral patent common iliac arteries and left iliac artery, external iliac artery without any hemodynamically significant stenosis, the occluded left SFA with the compensatory profunda or deep femoral. In summary about pre-intervention aortoiliac duplex ultrasound, it complements the routine diagnostic workup. It's good for selective use in pre-intervention assessment, and it may assist in determining appropriate intervention, particularly for endovascular interventions, and it may be able to predict the success of endovascular procedures, specifically by looking at is the disease diffuse, focal. If it's really vastly diffuse, this patient may not be a candidate for endovascular intervention. We can also determine if more focused or limited angiogram is appropriate rather than a full diagnostic angio. Many of these patients have other comorbid problems like marginal kidney function, and it may be helpful not to give them a full dye load. We may be able to determine the suitability of the endovascular repair versus an open surgical repair just looking at the anatomic structure, if it's focal versus diffuse disease, and what the hemodynamics are within the segments. This role in patient selection and procedural planning prior to intervention can be accurate, cost-saving, and time-saving, but it does require high-quality resolution equipment and experienced examiners and interpreters. We'll move on now and go from the pre-intervention to the post-intervention assessment. This is done with selective use. We're going to use both imaging and Doppler data just like we did in the pre-intervention and look at that pre-op for comparison. If there was a stent placed along the course of this intervention, we're going to look very carefully at that stent alignment and the relationship to the vessel wall. The rationale for looking at patients in the aortoiliac segments after intervention is knowing that identification and treatment of restenoses prior to complete occlusion may improve long-term patency. We know that stenoses are technically easier to manage than occlusion, and that PTA and stent procedures are associated with a pretty significant restenosis rate, and we want to find those and intervene prior to losing and having that segment go down. Well, beginning first with endovascular interventions, this is a standard aortic stent for stenosis. This is not an aortic stent graft. This is a simple stent structure like a stent anywhere, and you can see the linear stent structure within this aorta. We're going to walk the Doppler through this. In this particular case, there was some flow defined outside of this stent, and that would not be so unusual because this is, it can go through the interstices of the metal of the stent. What we want to do is make sure that there's no restenosis through the stent, look at the treatment length. So we're going to look at the inflow, the outflow, and the entire treated segment of that. This is an example of iliac stents. Now these are bilateral kissing stents. You can see in transverse here that they are in the common iliac right up to the level of the distal aorta. And we're going to look for good wall apposition and make sure that these are symmetrical and that they're fully deployed. We're going to get all the velocities that we need to get through all that segment. Usually if the patient has had a full aortoiliac and this is just a follow-up to a post-procedure stent, we would just do the terminal aorta and then look at the whole segment of the iliac since both iliacs were treated. We would walk the Doppler right on through the segment of the treated portion or of the stented iliac and confirm all of that with spectral Doppler in several areas. Most stents in the United States are nitinol, and most stents in Europe currently today are stainless steel. And even though most stents are nitinol that we see, depending on what the manufacturer is and how the stents are put together, they do image quite differently. You can see that these two have a very different imaging profile, but they're generally pretty easy to see, and if you rotate your hand back and forth, you can see where they begin and end, because those endpoints are important. You can see in this stent that there's still a plaque burden. This has crushed the plaque, but not all the way to the wall of the artery, so that leaves the end of this stent kind of hanging loose here and not quite all the way opposed to the wall, and that's something I'd want to note and keep track of as we follow that patient. Again, we're going to be looking for apposition to the wall of the artery, and you can see here another segment of plaque burden underneath this. The plaque has been crushed as far as it could crush towards the wall, but this is still a widely patent stent. These have a higher level of, or less of compliance, a higher stiffness level, and so there's going to be, in general, we expect some higher velocities through stented segments like this than we get in native vessels. And again, we're just really paying attention to this stent and the opposition to the wall of the vessel. Color is helpful to walk through there, and you can, again, just like in a native vessel, look for any alicing or places where you want to place your spectral Doppler. So we're going to assess the entire length of the stent with Doppler, looking at the pre-stented segment, the origin, the proximal, mid, and distal portions, and then the outflow portion of that as well. Here's an example of a common iliac artery stent stenosis, and you can see very easily where that is narrowed within the lumen. We document the elevated velocity associated with that. This one happens to be over 500 centimeters per second, and then document the post-stenotic turbulence and the decrease in velocity after the stenosis. This is an example of a subintimal angioplasty with stent. This is where they tunnel underneath and in between the intimal medial segment, create a new lumen in occluded segments, and then they may or may not place a stent within that to keep that segment open. And we have to walk the Doppler throughout that stented segment, just like we do with any stent. Here's an evidence of a distal stent where you can see the stent structure quite nicely up here, and then some turbulence associated right at the distal stent, and then going out into the native vessel itself. Here's a case example that's kind of interesting in looking for iliac disease. This is a routine graft surveillance, infrainguinal graft surveillance. The patient had had the graft for many years and came back in for follow-up, and we noticed that the velocities in the graft were in the impending failure range. The graft was pristinely clean all the way through. There was no areas of stenoses. These velocities had dropped precipitously from the previous study, so we knew based on the waveform morphology of a delayed systolic rise time that we had an inflow problem. The outflow was wonderful. There was no problem with it. So we just went up and followed, because this was at the anastomosis at the common femoral artery. We went on up until we found the problem, which was located in the very proximal portion of the common iliac, a very severe stenosis, over 330 centimeters per second. And this was then addressed. You can see the lesion here on angiogram, and this was addressed with a stent and repaired. His graft was fine afterwards, and since this was threatening his graft, it was good that this was identified early and repaired prior to him losing that very nice vein graft. So here's an aortoiliac stent case, 70-year-old male, referred for evaluation of lower extremity arterial disease. He had calf claudication and ended up with bilateral common iliac and external iliac PTA with stents. So here's what we would see. We've imaged and identified where the stent is. This is the pre-stent, the origin of the stent, and then walking through the stent, all of the Doppler velocity profiles that we need to capture to make sure that we thoroughly have assessed that stent. Then there's another stent in the external iliac, so here's the origin of that, and then proximal stent, mid-stent, and distal stent, and then the right hypogastric or internal iliac is documented as well. As we went further down, there was some increase in the peak systolic velocity at the proximal right external iliac artery and internal iliac artery with turbulence, but there wasn't a doubling of velocity, and there wasn't a lot of post-stenotic turbulence, so this was probably not hemodynamically significant. As we went further, down into the groin at the level of the femoral bifurcation. There was a large collection noted. This was measured. It was Dopplered to make sure that there was no flow within it, and this was probably associated with the original procedure at the time of stent placement, not affecting any of the hemodynamics of the vessels. Moving on to the left side, the left common iliac artery origin, mid-stent, distal stent, and then the distal vessel, all with relatively normal profiles. There isn't much reversal of diastolic flow, but there's some. As we go on down, we look at the external iliac and then the external stented segment, the mid-external iliac artery and mid to distal external iliac artery, and we've lost the reverse flow component completely by the time we get down that far. And then right as we get down to the interface with the common femoral artery, we see this very tight lesion by color. There's a lot of aliasing, and we see that the common femoral distal to that has an elevated velocity of 264 centimeters per second with post-stenotic turbulence documented. And here is where we see that the tightest portion, the highest velocity collected within that was 455 centimeters per second. So this was a hemodynamically significant lesion. We evaluated then on the runoff for that, the common femoral, the SFA, looking at the lesion. Now, your report on this would be bilateral patent common iliac and external iliac artery stents with a hemodynamically significant stenosis of the left distal external iliac artery right at the origin of the proximal common femoral artery, an incidental finding of that groin complex where we measured it with no associated flow and likely consistent with a hematoma. And this patient underwent an endarterectomy with vein patch angioplasty to address that lesion that we saw that was so stenotic. So duplex assessment following peripheral interventions, we know that identification and treatment of these restenoses may improve long-term patency. It's technically easier to manage a stenosis than wait for it to occlude. And we know that there is a significant restenosis rate associated with PTA and stent. We're going to use our imaging and Doppler data. We're going to look at the pre-op or baseline comparison and really pay close attention to the stent alignment and relationship to the vessel walls. I'm going to move on now from talking about endovascular intervention with PTA and stent and talk about duplex ultrasound following endovascular aortic stent graft, or EVAR. This is a increasing frequency of repair for aortic aneurysms in this country and across the world. And duplex ultrasound is a very good way of following these patients. There seems to be some resurgence of interest in duplex due to frequent CT scans causing an increased dye load and nephrotoxicity problems as well as radiation dose. So it's something that can be done. It's a valuable, reliable tool for post-operative surveillance of aortic endografts as long as you use a proper protocol. It is a much more complex and detailed exam than standard aortic ultrasound for, say, following up an aneurysm. And it is more sensitive to endoleak than, in some cases, than CT or even angiography because it's real-time and not tied to any kind of timing of contrast that has to be administered. The advantages of an endograft placement over open repair is that it's transluminal, small femoral incisions, the patients have a shorter hospital stay, there's less stress on the cardiopulmonary system, and there's less risk of impotence for the men because there's no peri-aortic dissection. However, there's a huge trade-off for these advantages, and that is that patients need more frequent surveillance and lifelong surveillance. We don't know what the long-term efficacy is. We know that there are different complications associated with this procedure than with the open repair. And we're going to talk about that. So in the surgical repair, there's a large transabdominal incision. Patients have to stay in the hospital for a good while to recover from this very large surgery, as opposed to the endovascular repair, where there is small femoral incisions made in cannulation with a rather large introducer, which is taken up, and then the device is deployed. The contralateral femoral is also used to deploy any extender cuffs or extra limbs associated with these devices. So there's a lot of patient acceptance for this. The problem is they don't always hear that the follow-up that they're going to have to adhere to. The complications we're going to look at with ultrasound are those that are associated with any catheter-based intervention, such as hematoma, a pseudoaneurysm, intimal flaps, intimal dissections, or AV fistulas. But the main things we're going to be looking for is aneurysm enlargement, which is very important because, after all, putting the device in is supposed to prevent the patient from having an aneurysm enlargement and hopefully have it shrink. Endoleak is a common complication that's associated with all of the devices that are currently available. And then limb dysfunction or thrombosis, we'll talk briefly about that. You need to know which complications to anticipate. Complications can occur early on in the course of the patient's follow-up or anywhere along the course. We've seen patients who had absolutely no complications and no problems for 8 or more years, and then suddenly, due to changes in morphology or recurrence of aneurysmal disease, or being placed on anticoagulation, suddenly develop new complications many years out. Be aware of the unique complications associated with the different graft designs. Different devices will have different complications associated with them. Our purpose of looking with ultrasound at these endografts is really to monitor this aneurysm size and make sure it's not enlarging, because aneurysm contraction ultimately determines the operative success of these, and we know that we can follow the aneurysm size accurately to follow these serially. Endoleak is common with all of the devices, and we'll talk quite a bit about that. And then limb dysfunction is any anatomic or hemodynamic impairment that's going to threaten the function of that graft. You need to know the surgical or endovascular details of this device placement prior to looking at it. You need to know the type of device, whether it was modular, whether it was single body construction, if they did any concurrent procedures such as coiling of the IMA or hypogastric, or any of the additional stenting, any additional limbs that they had to put in. And in some centers, they try to measure the distance inferior to the renal artery to look for migration of the device as well. The device design comes in different configurations. The bifurcated stent graft is the most common one that you're going to see, although there are configurations of a straight tube stent graft that doesn't have limbs. And there's also not approved for FDA use in this country, in the US, but there are devices out there that have been put in through trials of uni-iliac stent graft that requires occlusion of the contralateral iliac and then a femoral bypass to supply the contralateral limb. These come in a supported, unsupported, modular, and single body construction configurations, so they can be very different. In the United States, there are only 4 currently FDA approved for use. That's the Aneurysm device, the Gore device, the Cook Zenith device, and the Endologics device. All of these have different configurations and image quite differently. Some of them are modular and some of them are not, so you really need to know what you're looking at and follow those appropriately. The graft design is really important. We're going to use appropriate equipment, high definition, high resolution at depths appropriate for the aorta. This is not a study that, again, that you want to do with one of the smaller laptop type systems, because we need robust, good color and spectral Doppler very deep in the aorta. Many aortas are 15 to 20 centimeters down. We're going to use low frequency transducers. We're going to use the B-mode color and spectral Doppler. And we may need to reposition the patient several times during the course of the exam. One tip I can give you is if you can push down on the patient's abdomen to bring the aorta into about the 10 centimeter depth range, you'll have much better imaging quality and much better identification of endoleak. We usually do these patients in the morning so they don't swallow air all day. For the same reason, we keep them fasting and no smoking or gum chewing prior to the exam. Ask them to have a light, low-fat supper and not eat anything that would normally produce gas for them the evening before. Use the supine and decubitus views, whatever view works for that particular patient, and always look at it both in transverse and sagittal planes. The examiner should be very familiar with visceral vessel anatomy, particularly the IMA and iliacs. They should be very comfortable scanning in the abdomen, and I found that experience with a lot of renal studies, renovascular studies, helps them in segueing to this exam. There's a longer learning curve than most studies, and again, it's more complex than standard aneurysm ultrasound. But this is a study the examiner really has to want to do and want to do completely for this to be successful. The first thing I would say is that size matters. We really need accurate B-mode measurements, and we can do that in either transverse or longitudinal, preferably transverse. In the center in which I worked in Norfolk, Virginia, we looked at this and did a study that was published, and I'll give you that reference in a moment. But what we found was we compared standard axial CT to orthogonal CT and ultrasound. And what we found is that axial CT is going to overestimate the size of the aneurysm directly proportional to the angulation, the amount of angulation in the neck of that aorta. So here you see that if we drop an orthogonal plane into this, where we can truly be perpendicular to the aorta, we're going to get a smaller measurement than the axial CT is going to get being transverse to the patient's body. There was no statistical difference between orthogonal CT measurements and ultrasound, so we know that sonographers can correct for angulation with their hand by making the fusiform aneurysm round and measuring appropriately, and this is what I mean by that. So you can see that this axial CT on that angulated neck of that, with an angulated neck, you can see that the residual aneurysm is ovoid, not round, where with an orthogonal cut it is round, just like in ultrasound, where we can correct for aortic angulation with our hand by making it perpendicular to the aorta, not to the patient's body. Here's the reference I was talking to you about. This was published in 2004 in the European Journal of Vascular and Endovascular Surgery with the main author of Richard Sprouse, looking at all of this data. This is a good orthogonal measurement. This is what we want to see, a nice round residual aneurysm sac in which we can measure appropriately for that follow-up of those serial studies. Endoleak is a very common complication after EVAR. It's reported in up to 50% of endovascular repairs. In the two major trials, FDA trials that were done in the United States, there was a 30% endoleak across all time points. This is defined as flow outside the endograft but within the residual aneurysm sac and exposes the aneurysm to continued hemodynamic stress that would lead to potential expansion with the risk of rupture. It's most commonly originating from residual branch vessels, type 2, like the lumbars and the IMA. All of these references document that we can find endoleak in up to 50% of patients following EVAR. The protocol for looking for endoleak is to use B mode. There are a lot of clues with B mode that can tell you where to look for endoleak. We're of course going to use color flow within the graft and within the residual aneurysm sac, looking at all potential leak sites. So if any attachment or fixation site or a modular connection sites where the IMA would normally come in, and looking for lumbars. And then that has to be confirmed with spectral Doppler, because there can be some very convincing looking color flow that isn't truly a leak, and you have to confirm that with spectral Doppler. If you're scanning and you see B mode clues and you've got a real strong suspicion that there's an endoleak and you're not able to identify it really easily, reposition the patient to a flank position, rescan in those suspected areas, and you may be more successful. We're going to look also in B mode for several things. We're going to look at the attachment sites so you can see where the device begins and ends. Here's an inferior. You can see that strut structure quite nicely. We're also going to look at the B mode appearance of the residual aneurysm sac. We know that normally thrombus is homogeneous, and here you see this little hypoechoic area. I would really strongly investigate that for a leak area. If you ever see in an unsupported graft wall motion during the cardiac cycle, that means that there's more pressure out here outside the graft in certain portions of the cardiac cycle than within the graft, and that's almost always associated with an endoleak, graft deformation that looks like this during certain portions of the cardiac cycle. The other thing that we published about in 2005 was the appearance of a spongy-like texture to this thrombus within the residual aneurysm sac. This was usually associated in a small series of patients with very pressurized sac and very low flow endoleak that created aneurysm expansion of up to 0.5 centimeter a year. So it was significant aneurysm expansion associated with this particular B mode characteristic. So here are some examples of those spongy sacs that were likely to lead to aneurysm expansion, and you can see that they are very heterogeneous and almost have this sort of thread of flow going through wherever it can kind of seep in around the thrombus. And these were the ones that did result in significant aneurysm expansion. When we're looking with color, we want to use real-time color flow that will identify the source of the endoleak and the flow direction. Your PRF has got to be set very, very low, your wall filters low, your gain set high, because sometimes these are very low flow states. So you really need to optimize your system for that. Then you confirm the spectral waveform of that endoleak and make sure it's not an artifact. We do know that some of these very small leaks can cause systemic pressure within the residual aneurysm sac, and we know that from direct pressure measurements at the time of explantation from some of these patients. The color sensitivity should be very high, and we're going to image slowly from proximal to distal, from one attachment site to the other, optimizing for looking for endoleak and looking at the thrombus and making sure that that is a thrombosed site. We need to be aware of those potential sites of perigraft leak. A true leak will have usually different arterial waveform characteristics than that of what's in the graft, unless the graft is what the origin of the leak is. This is an example of a biphasic flow. In general, biphasic flow is associated with something that has an inflow and an outflow, whereas the bidirectional flow, as you see in this picture, is associated with something more similar to the waveform characteristics of a pseudoaneurysm, where there's flow in systole and drags back out in diastole. That's usually representative of a leak that only has one source. Occasionally we'll see two colors within the limbs like this, and you think, well, these are supposed to be going in the same direction. Why are they in two colors? Well, frequently they will cross the limbs, and you will see one of them more angulated, and in the transverse view like this, it's going to appear that it's going in a different direction when it's actually not. So let's talk about the different types of endoleak. We have the anchoring system or attachment site endoleaks, that's type 1. We have the intersegmental junction modular endoleaks, that would be type 3. The most common kind, is, of course, is the branch vessel or type 2 coming from patent lumbars or IMA. And then type 4 is transgraft or through the porosity of the graft fabric. Any of these can cause pressurization of the sac and aneurysm expansion, and we don't know which ones will and which ones won't. Here's examples of these different types of endoleak. Here is a superior attachment endoleak. Here is an IMA endoleak. Here's a lumbar endoleak with that two-fro flow. This is an inferior attachment leak, and we need to look for all of these. This is a type 1 or a distal attachment leak. There was not a good seal due to calcific plaque at the distal common iliac. And here you can see flow going towards the foot, depicted here in sort of a pink-red color, and then back up towards the aneurysm sac, adjacent in this iliac artery in blue. You can see retrograde flow. Because this was originating from the graft itself, it had the same waveform characteristics of the graft and was biphasic. This is that patient that had the superior attachment leak, and if you look here, you can see that not only was it leaking there at the superior attachment and scooting up adjacent to the device, but it actually was feeding the existing IMA in the correct direction, going out into the periphery there. This is a type 1 endoleak from the inferior attachment. Here you can see it on angiogram, CT, as well as on duplex. This is a typical type 2 endoleak. Here is a whole nest of lumbars that were patent. You can see it's causing a large endoleak in between the two limbs of this graft, and this is about a month later a 3D reconstruction CT was done depicting the same type of endoleak. No modality is going to miss a very large IMA leak such as this one. This one is very easy to see. You can see that it's causing some movement of the graft wall right here. This much more subtle, smaller lumbar leak is the one that is much more difficult to define and look for, and takes a bit of skill to do. Here's another IMA that has sort of a bizarre flow pattern entering the aneurysm sac. This is an example of the lumbar where you see in both longitudinal, transverse, and you can see that lumbar feeding the posterior portion of the sac, as well as the bidirectional flow confirmed on spectral Doppler. So we have all three views that we need to confirm that endoleak. Type 3 endoleak, this is a disconnect of the modular interface. Here you can see angiographically, and it was causing this big, huge leak you can see on the Doppler here by the color, right where this was disconnected here. Here's another type 3 endoleak seen on CT as well as duplex ultrasound confirmed with spectral Doppler. This is a type 4 before and after a wall graft. I don't think that we will ever be able to tell the difference by ultrasound between type 3 and type 4, but you will know that it's there and suspect that it's not something associated with branch vessels. The pitfalls in endoleak detection is that there's a wide discrepancy in the rates of the endoleak that is detected. Small leaks are often more difficult to define, and we know that leaks more difficult to define in the supported endografts, and all of the available endografts in the United States today that are on the market are supported. So that makes it our job a little bit harder. There are differences in device design and construction that affect our ability to detect endoleak, and that's due to wall oscillation and pressure transmission. But we do know that small leaks can cause systemic pressure within the aneurysm sac, so all of them are important until proven otherwise. There may be a role for ultrasound contrast, although this is an off-label use. We used it in our center to help us to identify those patients in whom we thought Duplex said there was endoleak and CT was negative, and the ultrasound contrast confirmed those that were positive really for endoleak. So let's leave endoleak for a moment and talk just briefly about limb dysfunction. Unsupported endografts are more at risk for limb dysfunction, and even though there are no more of those on the market, there's quite a few patients out there with unsupported limbs from the ANCure device. We can effectively identify any problem that is going to threaten the graft patency: twisting, kinking, bending, tortuous iliacs, incomplete deployment occlusion, and aneurysm remodeling over time. So here's an example of limb dysfunction early on. Here is a stenosis. You can see a high velocity. This was early in our experience, was reballooned, and we have a nice normal triphasic flow. When we talk about aneurysm remodeling, when these aneurysms start to shrink, they shrink, and sometimes this happened to be a uni-iliac graft, and it became very redundant and kinked on several occasions. And you can see here angiographically how kinked that was. And remember, if this is an aorta uni-iliac, it's supplying both limbs. So this is a real problem. But over time, the morphology of that residual aneurysm sac can change, and if that graft becomes redundant, then this has to be addressed. This is what we don't want to see. This is an endograft occlusion in this limb. And here's an example where you see that this limb, the right limb, is flattened, occluded, and very different in appearance from the circular, normal left patent limb. So the advantages of duplex ultrasound after endovascular aortic repair is that we can provide very accurate residual diameter measurements of the aneurysm sac. We can be very sensitive to endoleak detection, identifying the source of it, the direction of flow. We can evaluate limb dysfunction, any other hemodynamic impairment that might threaten the graft. It's relatively inexpensive, reproducible, and does not require any contrast. And I believe there's an additive effect of CT and ultrasound and follow-up of these patients. The disadvantages is that it does take a time commitment. It usually takes about an hour or so to do these studies thoroughly. It is a technically challenging study. However, with proper training and desire, most labs or facilities can do this well. You do need high resolution or the more expensive type of equipment because you need something with very robust spectral and color Doppler. But the hardest thing, I think, and the biggest disadvantage is that making patients understand that they are committing to lifelong follow-up and compliance with that follow-up so that we can identify any complications that may occur over time. Thank you.